Welcome everyone to Research, Resources, and Refreshments. A big shout out to all of you in Kansas City. Grab your refreshments now. And for those of you who are online, grab your refreshments also because we have an outstanding lineup of speakers that you won't want to miss. I'm Sharon Loftspring and I serve on the board of NF Central Plains and the NF Network, your two hosts for today's program. I want to thank our NF Central Plains board members. I think most of them are there now. Jill and Shelly and Kami, Tyler and LaRue, who helped make our KC Watch Party happen, along with the network, the NF Network staff, who does so much work behind the scenes. I especially want to thank our sponsor, SpringWorks Therapeutics, for its generosity and support in making this program a reality. And I want to welcome all of you SpringWorks representatives who are joining us virtually today. And I can't forget to thank my daughter, Alana, my reason for being involved in the NF community, for handling so many of today's details, and my husband, Peter, for his technical support. A few housekeeping announcements before we start. We'll be moving at a fast pace given all that we have to share with you. So to save time, we'll only be making very brief introductions of the speakers. I encourage you to check out the NF Network website's event page for their full biographies and other materials related to the presentations. If you have questions for the speakers, please post them in the chat room, and we'll do our very best to answer as many as possible today or after the program. Finally, in between each of the speakers' presentation, we'll be sharing a resource that may be beneficial to you and your family. Many will have QR codes or links to the resource, so watch for those. They'll also be posted on the NF Network's website if you go to the event page for this program. Now it is my pleasure to introduce Dr. Renee McNeil-Knapp, who will provide a brief overview of the NF research landscape and the exciting treatments in the pipeline. Dr. McNeil-Knapp comes to us from the University of Oklahoma, where she specializes in pediatric hematology and oncology. Welcome, Dr. McNeil-Knapp.
Thank you so much for having me. This is a near and dear group to me. I am a pediatric oncologist by training, but when I was in medical school, my sister was diagnosed with NF2. And so this has been part of my journey as well as a family member only, though. Were you guys going to share the presentation, or do I need to share it?
If you could share it, whatever's more comfortable, if you could share it, that would be fine.
Okay. I think I can share it. So let's try.
I can have it if you need me to.
Yeah. Okay. And I will make this full screen and presentation mode there. You guys all seeing that fine?
Yes.
Great. All right. Well, I am talking about treatment of tumors in neurofibromatosis. And, you know, a tumor is an abnormal growth. That's all it is. There's a lot of weight placed on that word, but it's just an abnormal growth where it's not supposed to be. And of course, what makes this diagnosis both in type 1 and type 2 is the growth of tumors. In NF1, almost 100% of patients have developed neurofibromas. And I'm going to show you the difference between those and plexiform neurofibromas, which are seen in 40-50% of patients. And we're going to talk just a bit about the other types of tumors that we see, both in NF1 and NF2. There are other tumors besides the ones we're going to talk to that are more common in people with NF1. In particular, our women out there, breast cancer is more common, ovarian cancer, and there are other things that it's important to see your provider yearly to get the appropriate screening. Neurofibromas are a simple growth, but they can have multiple nerve fibers growing within it. A schwannoma usually has one nerve fiber that it's growing from, and those are more common in NF2. The plexiform neurofibromas are seen at the bottom of this slide, the picture on the bottom, which is multiple growths, different nerve fibers, all connected in a large diffuse mass. And a lot of those are present very early in childhood, even at birth. And that's where we're going to focus some of our attention today because there's been recent developments in that treatment of those types of tumors. Unfortunately, these neurofibromas can become malignant. Those are called malignant peripheral nerve sheath tumors. And when you should worry about those is if one of your neurofibromas is growing faster, feels different, especially if it's more firm, more round. And the best way to tell if it's something we need to worry about is to do a PET-CT, which is a special scan that you get radioactive glucose to the injected, and so you can see where the glucose goes. And if the tumors take up a lot of that or are hot on PET scan, then those are more likely to be malignant than the ones that are less active. So when we worry about treating neurofibromas, especially plexiform neurofibromas, is when they are causing dysfunction of important functions. Like I've had patients who have tumors near the spine and they get weakness. Ones that are like this young man in the neck, they can involve the airway, cause trouble with swallowing or breathing. I've had patients that have intra-abdominal ones that are surrounding the bladder and rectum and cause lots of problems there. So that's one indication. The other two big indications are pain. We know that these neurofibromas can be quite painful, very tender when touched, or if they are very cosmetically disfiguring. And I included this picture from the landmark study of using selumetinib in children with neurofibromatosis who had plexiform neurofibromas. And of course, they shared one of their better responses there, where you can see on the left is the patient with his big neck plexiform neurofibroma at baseline and after 13 cycles on the right. So neurofibromas, generally the treatment options are surgery. And in plexiform, that can be very difficult, plexiform neurofibromas, because they are so extensive and you can't take the whole thing out without difficulty. So lately, the recent updates are that we are using drugs that are targeted therapy downstream of the mutation in the neurofibromatosis gene, and that is called a MEK inhibitor. Selumetinib was approved just about 3 years ago for pediatric patients under 18 only. And this year, mirdametinib has been submitted for approval for pediatric and adult indications based on a study that we just reported. I was fortunate enough to be part of this study, and we are reporting the data that shows that on average tumors are shrinking about 40 to 50% in volume with treatment with this mirdametinib. And if it is approved by the FDA for adults, it will be the first therapy approved for adult plexiform neurofibromas. For malignant peripheral nerve sheath tumors, the reason you want to catch those early is because if you catch it and you're able to take out that rapidly growing tumor, then you just have to observe otherwise. If it's later, we are talking about surgery, radiation, and possibly chemotherapy. There are studies ongoing of using these MEK inhibitors that we're using in plexiforms and other targeted therapy along with the standard therapy for these tumors. So, so there's got to be a downside in a drug that would shrink a tumor 40 to 50%. All of our magic comes with some sort of cost, unfortunately. And so what's really important as you're considering whether this is the right thing for you or your family member is that these MEK inhibitors don't work quickly. It's a very slow shrinkage of the tumors. Sometimes when you're just seeing the mass, you don't see on a day-to-day base how much it's shrinking. It's taken orally twice daily. The selumetinib is an oral capsule. The mirdametinib does have a dispersible tablet available for smaller patients, which is going to be really nice if it's approved, as we expected. And you take those twice a day. The mirdametinib, you also get a gap. You take it for 3 weeks and don't take it for a week and then take it for 3 weeks again. But it's a pretty continuous therapy that has some significant side effects for some people, especially my adolescent patients and adults have more incidence of the skin side effects. And the most common side effects in the skin are in that group, like an acne rash on their face, chest, back. It's more dry than acne is, and is treated in a slightly different way. We do have treatments to help with that, but it can be pretty significant. The GI symptoms like diarrhea and upset stomach, some abdominal pain can happen. Rarer side effects, excuse me, but more important are in the eyes. Our patients can get either blood clots to the back of the eye, or they can get what's called retinopathy, which is damage to the back of the eye, the nerve layer in the back of the eye. I've never had anyone experience any vision loss from that outside of maybe a little blurry vision, but that is a rare side effect that can cause some vision loss. More common, but still we try to catch before it causes any problems, is it can cause problems with the heart muscle contracting. So if that weakens, that can be heart failure is what we're looking at. So in order to watch for that, we do echocardiograms or ultrasounds of the heart every 3 months while patients are on these inhibitors to look at that muscle strength and make sure the heart is pumping that blood very efficiently. If it weakens, you stop the medicine, the weakness should resolve back to normal, and you can restart at a lower dose. But of course, anything that affects the heart can be very concerning. If it caused permanent heart damage, it would cause shortness of breath and edema. But again, that's not anything I've ever seen. It's always resolved with taking patients off the medications. So you've really got to weigh, as you're looking at these kind of medications or any medications, the risk versus the benefit. And knowing you'll be on it if you start it, even if it's effective, it's usually 2 years or more of therapy. I have noticed, though, that my patients who start at an earlier age have a better response rate, I would say. The other thing that there's been a change in our therapy is gliomas in NF1. You may know that these gliomas or tumors of the nerves in the brain, the most common in NF1 is the optic pathway glioma, where you see these arrows is thickening of the nerves of the optic the optic nerves, which because of the location, not only because it causes vision loss, we see a lot of hormone problems as well with that. You can see gliomas elsewhere, but optic pathway in young children is kind of the most common thing we see. If you have a young child with neurofibromatosis, very, very important to see a very good pediatric ophthalmologist routinely to screen for this, starting the minute you suspect that they might have NF1. And the treatment, the standard treatment has been for years and years and years. I'm not a young doctor. I've been practicing for 25 years, and all that time, the standard treatment has been chemotherapy, which is given IV weekly for about 15 months. And that's been very effective in patients who need treatment. Not every patient who has an optic pathway glioma needs treatment, but those who have growth and problems that need treatment, it's very, very effective, but it's very burdensome. Now they're doing trials of that compared to selumetinib, that MEK inhibitor we discussed in the plexiforms. And there's other options that are coming down the pike as well of more targeted therapy. So in NF2 patients, we worry about, of course, the vestibular schwannomas, meningiomas, and ependymomas. There's not really anything newer on this, but we are doing clinical trials looking at newer therapies, but we do have some targeted therapies and radiation for those. So what's important is if you have, NF, no matter what your age, you need to be seeing a specialist in neurofibromatosis to screen for tumors because they'll know what to worry about, or, once you're worried about a tumor, to see them and see what's the next appropriate step. Genetics providers are a good place for all ages to go, and neurology, genetics covers all ages. In neurology, if their patient is under 18, they should go to a child neurologist, or if they're over 18, an adult neurologist who knows about NF. Our team, I have a picture of our team, but there's teams in Kansas City and elsewhere. We're in Oklahoma City. And we take care mostly pediatric patients, but we do have a provider who is taking on adult patients as well. If a tumor is growing or, something that's been there, it's slowly grown over time, but it's changing in other ways, tell your provider. If you feel something, really tell people, because we'd rather catch things early when they're easier to treat than later. And that's all I have for our presentation, my part of the presentation. I'm open for questions if you guys have any.
I was just looking in the chat and I don't see any questions, but I can tell you that we're very grateful for you giving us the overview today, and just exciting to know that there's some research coming on. So very excited to look forward to that. Thank you so much, Dr. McNeil-Knapp.
Well, thank you for having me. Like I said, this is a group near and dear to my heart.
Thanks so much. And here's your first resource.
Hello. I'm sorry. Go ahead. It's loading.
It's coming. And I'll tell you what you're going to be seeing. Your first resource.
Can you see it?
Yes, your first resource is a travel card that was developed by the NF Network. And some of you may have heard about the incident recently on Southwest Airlines where a woman was removed because she had had some of her facial tumors removed, and she was asked to get off the plane. I think they assumed that she was contagious. And we just don't want that to happen again. So the card that you see or there's a QR code for, explains what NF is in factual terms and that it's not contagious. And it also includes links to the TSA's resources for travelers' safety. So I encourage all of you to check it out. I'm holding it up so you can see how small it is. It will fit in your wallet or your purse when you travel, or if you see somebody who might need the resource. But I encourage you all to either use the QR code or check the NF Network's website to get a travel card. Thank you so much. And it is now my privilege to introduce Michelle Sass, an educational consultant and advocate. She will be speaking on a topic that many people in our community have struggled with, which is how to make sure our kids get a fair shake in school. Welcome, Michelle.
Thank you, Sharon, and thank you for organizing this event and inviting me to be here. And thank you all for being here. Let me start off by saying that I have a similar issue as some of you, that I have a child with disabilities, which is also a rare genetic condition, and which prompted my second career in advocating for people with disabilities and students with disabilities. So I've been in similar shoes as you, and I'm really passionate about what I do, advocating for people with medical conditions, learning disorders, and other disabilities. I'm going to be breaking the PowerPoint rules today because I'm going to be having a lot of information on my slides, as I wanted to be sure that I communicate everything you need to know and want to stay on track due to the time constraints. So I'm asking you to please hold your questions till after, and I will try to answer at the end of my presentation, but also feel free to contact me on my website contact page or email me. And I do offer a half-hour free consult to determine if I can help you. And I offer pro bono work for those of you that can't afford my nominal fee. And I'm booking out to mid-November. So just wanted to give you a feel of that real quick. And I'm going to go fast. Okay, let me share my slides. Whoops, did I lose you?
We still see you.
Great, thank you for letting me know, because I'm going to share. Let me go back to my Zoom. Sorry, I'm a great advocate, not a great.
That's all right. We are a forgiving group.
Why don't I see the share tab anymore? I'm so sorry. There we go. Share.
We can see it.
Okay, can you see the whole screen? Or is it not full screen yet?
It's not full screen yet, but we definitely see your first slide.
Okay, great.
At the bottom, if you want to click where the sliding scale is, the button right next to the minus. At the bottom. Keep going to the right. Yeah, the button next to the minus on the left of the minus. No, just the little square button on the left of the minus.
Hang on. Just
Looks like a screen.
Yes. Or you can just do play from start on the top left.
top left. There we go. Okay.
Great. All
Okay.
good.
Apologize. So if you want to quickly jot down my email address and my website, and I'll show this slide again at the end. So if I go too fast for you, let me know. Okay, I'm going to move on. Okay, so my consulting focus has primarily been on middle to high school students in obtaining SAT, ACT, and AP accommodations, but it also translates to academic classroom accommodations. And a lot of what I'm going to say is relevant to younger children and also adults as well, who are maybe going to take exams for some kind of certification or licensing, etc. So I view the educational accommodations process as a team approach between the student, the school, and the parent, or in the case of an adult, between you and your employer or your testing entity. My role is to assist parents in the process. I help people put the puzzle pieces of their child's educational needs together. And I'll address more about that, about my role later. But so question, what is a disability? So in my world of accommodations, it is a physical or mental impairment that substantially limits the major life activity of learning. And it can be a medical condition such as NF and the symptoms of that, and or a specific learning disorder, or in most cases, both. Therefore, I'll be using the term disability for today's discussion to encompass any condition which limits the major life activity of learning. So it's important to know that it's been my experience that many students have one or adults, doesn't matter. A lot of times it's adults or students, have one disability, have other disabilities as well. So people generally that I've worked with, based on my experience, have more than one disability. It's equally important to note that everyone is unique, and the necessary academic and testing accommodations for one person with a particular disability will most likely not be the same as another person with the same disability. For those of you that have babies, let me start off by saying that, or young children through pre-K, with any developmental delays and or disabilities, it's really important to seek out early intervention, which is a free local program whereby evaluators, educators, therapists come into your home for free and provide needed services, which may include speech therapy, physical therapy, and other types of services based on the needs of the child and family. And this is really important to be able to get your child ready for school and help them grow. So some examples of medical conditions and disabilities that I've worked with are ADD, ADHD, traumatic head injuries, such as concussion, learning disorders, dyslexia, dysgraphia, which is a writing disorder, dyscalculia, which is a math disorder, psychiatric disorders, generalized anxiety disorder, tic disorders, Tourette syndrome, visual impairments, hearing impairments, ulcerative colitis. I mean, the list goes on. And again, I just want to reiterate that a lot of times my clients come to me with ADHD, for example, and I learned that they really have other disabilities as well. And it's really important to learn that for their success. So some students with disabilities, depending on the severity, may have both classroom and school-based testing accommodations. The accommodations are shown either on an individual education plan, an IEP, or a Section 504 plan. An IEP has measurable goals and timelines in which to achieve those goals and can show accommodations. A Section 504 plan is most often used for a true, what I'm going to call disability, and can show accommodations. So if a student is in a private school, the IEP will have another name, such as a learning plan, a learning enhancement plan. Both an IEP and a Section 504 needs to be established by the district. So the question begs, which should my child have, an IEP or a 504? So I recommend that for elementary years, this is based on my experience, that a student with a disability have an IEP because it can contain specially designed instruction with measurable goals. So as far as their school skills, they can have goals in which they can be measured, and it's really important for the elementary years. So they're intensive and beyond what is typically offered in the general education classroom. For middle school, or at least starting in 8th or 9th grade, I highly recommend that a student transition to a Section 504 plan. An IEP ends when a student graduates from high school or at age 22, whichever comes first. A Section 504 stays with the student through their adulthood beyond high school, which can be important for such things as graduate school entrance exams, licensing exams, certifications, and other tests. I strongly recommend that the school does not give unofficial accommodations to your child as extra time on exams, assignments, etc. This is a true disservice to your student. It is so important to document that the accommodations that the student has, that they be documented and utilized by the student, and there's a record of it. For PSAT, SAT, and ACT and AP accommodations, the process, which again can help identify additional classroom accommodations that are needed for both high school and college. And for the purposes of today's discussion, I'll be only talking about students whose disability is not severe enough to preclude them from taking the SAT or ACT exams. There are obviously many students with disabilities who are unable to go to college. And there are many students with disabilities that cannot take the college entrance exams, and many colleges don't require them. And there are also colleges with special programs for students with disabilities. So many of you might be thinking, my child already has an IEP or a Section 504 plan, so they're all set for SAT, ACT, or AP testing accommodations. Well, this may or may not be true, and it usually is not true. There are many standardized test environment specific accommodations for the SAT and the other exams that may not be included in your student's plan. Many schools apply for standardized test accommodations that are already on a student's plan and don't take into account this specific standardized test environment accommodations. That's a mouthful. Again, it's the specific standardized test environment accommodations that are needed by the student. These schools often apply for these accommodations without the input from the student and the parents. These are high stakes exams and up to 4 hours long, although they're shortening them, with just a few breaks. So it's important that students with disabilities be able to perform on a level playing field. For a student I helped, for example, a client that I helped with NF also had or has ADHD and generalized anxiety disorder, and had the accommodation of 50% extended time for school testing. So again, most districts will then just apply for that 50% extended time. And this student also needed standardized testing accommodations of stop the clock breaks as needed to take breaks and refocus due to their ADHD and anxiety disorder. They also needed multiple day testing. So I was able to accomplish getting those accommodations for that student. So I just wanted to share that example. Some other examples are a student with obsessive compulsive disorder may need someone to bubble in the answers for them so they don't obsess. Is it dark enough? Is it full enough? Someone with dysgraphia may need which is a writing disorder, may need a scribe. Someone with a vision impairment or dyslexia may need a reader to read the exam, bubble in the answers. The list goes on. There's many accommodations out there. Again, most IEPs and 504s do not include standardized test environment specific accommodations that are needed by the student. The American Disabilities Act is why these testing entities are required to provide these accommodations. This is just a provision of the act, which I'm going to skip. And this is why the testing entities need to provide these accommodations for students with disabilities. When a person is taking the test should be measuring the knowledge of the person and not demonstrating the disability, thereby enabling the student to test on a level playing field versus their peers. Accommodations for the exams are for PSAT, SAT, AP tests are handled through College Board, and they must be applied for through College Board. ACT accommodations must be applied through ACT. All accommodation requests should be handled through the school. My role in the services I provide as an educational testing accommodations advocate is again a function of being a team approach. I help parents put the puzzle pieces of their child's educational needs together. The process begins, as I said, with a free initial 30-minute phone consult. And then I do a thorough deep dive intake, reviewing all of the child's evaluations, medical diagnosis, medical reports, existing IEPs or Section 504s, and seek parent and student history and input. I determine if prior evaluations or reports are current and sufficient based on the testing organization's guidelines, and whether other evaluations or reevaluations are required. I provide additional documentation in order to support the requests. Also, with my client's permission, this is a big piece of what I do, I confer with their child's doctors, the psychologist, psychiatrist, the specialists, and seek input and alignment on the accommodations needed for that child to obtain further substantiation documentation. So I then draft a letter for the specialists to author on their letterhead so that every piece of paper that College Board or ACT has the same accommodations. And this is where it really comes into play, even if the child is not applying for for SAT and ACT accommodations, that they can, I'm sorry, I've lost my train, that they can have updated evaluations so that everything is current and they know where they're at, so to speak, in terms of the accommodations they need for the next educational step. Recommended revisions to a student's I recommend revisions to a student's education plan, private school plan, so it includes all of the classroom and standardized test-specific accommodations that are needed for the student. I then draft a cover letter from the parent, so I help write it for you, for College Board and ACT, which summarizes all of the requested accommodations and substantiations. I provide referrals for outstanding psychological testing, academic tutoring, skill building, essay writing, all that, depending on the location of the client, and provide guidance on the college search process as related to accommodations, accessibility, and things may be, depending on the disability, may be very different for college. This is my disclaimer slide. I am not a lawyer. I just wanted to say that. I pull language in from the American Disabilities Act into the documentation, but I am not an attorney and do not pretend to be one. I'm just an advocate who cares a lot about students with disabilities. And again, here's my contact information. And are there any questions?
Michelle, there are no questions that I can see in the chat right now, but I have 2 questions for you.
Okay.
One is, I assume you can work with people from all over the country. You can just do your work remotely. Is that right?
Yes, I have worked with people from all over. Yes.
Okay, great. And then the second question is, just in your experience, has it been difficult to work with? Are there certain school people within the school district that are easier to work with than others, just in their position, whether it's school nurses or school administrators or teachers?
So that is a very good question, and thank you for asking it. I think that the schools kind of in general, get a little defensive because this is really their job. And I don't work so closely with the schools kind of until the end. Because I should back up and say, I recommend that evaluations, if a parent can afford it, be done privately through a neuropsychologist or an educational psychologist, and that not to rely on the district, who's going to be give more of a bare bones evaluation. The neuropsychologist or the educational psychologist casts a wider net, so to speak, to capture any type of disability that might be present. And then once we present the data to the school, it should be no question, because every specialist says the same thing. I put the same list of accommodations on every letter, so they really they tend to get it at that point.
Great. Well, thank you very much. Are there any other questions? I'm just looking to make sure. But I think we're good. It's a wonderful resource to have. Many of us have struggled with this issue, so I'm thrilled to have a resource now for that. So thank you very, very much.
Thank you.
And here's your next resource. Take a look. Your next resource has to do with being a caregiver. A lot of the focus is on patients, and sometimes those of us who are caregivers need the support as well and need the help as well. So I'd like to direct your attention to this. It's called the Self-Care Institute, and it's run by Dr. Ami Kunimura. She offers articles on her website on resilience, learning how to say no, which many of us have trouble doing, recognizing how tired we are, and how to avoid burnout. And it's a very worthwhile resource for caregivers of those who have a chronic illness, especially. This institute offers a free weekly newsletter you can sign up for on the website, and there are a lot of self-care tools and practices on the website. So I encourage you to check it out. And now our next speaker is Dr. David Miller, an associate professor of pediatrics at Harvard Medical School and director of the NF Research Initiative at Boston Children's Hospital. He will be telling us about an exciting research project that he's leading, and we're very honored to have him here. Welcome, Dr. Miller.
Please make
And
sure
Dr.
that
Miller, if you'll unmute yourself, but we can see your screen.
Oh yeah. No, I was having trouble on the laptop with the unmuting. I'm not the most technically gifted person either, Sharon. So, but thank you for having me.
Company.
It's a pleasure for me to be able to speak with you all today, and thank you for inviting me. And as you mentioned, I'm a medical geneticist. I work at Boston Children's Hospital, and I work in the neurofibromatosis clinic. I see mainly patients with NF1 up through middle 20s usually. And then we have a wonderful adult NF program over at Mass General Hospital, and that then a lot of the patients graduate to there. And I'm really glad that you had Dr. McNeil Knapp talk earlier, because she gave a really wonderful overview of different types of tumors that happen in NF1, and that gives a good segue into me talking about what I'm going to talk about, which is related to one of the tumors she mentioned called the malignant peripheral nerve sheath tumor, or MPNST. So the goal is to talk just a little bit more about that one specifically, and talk a little bit more about how early detection could help with treatment, which Dr. McNeil Knapp already kind of alluded to. And we're going to talk about what a liquid biopsy is, and about clinical trials related to the liquid biopsies for adults with NF1, and then also I have some information about for pediatric children patients with NF1 as well. So you already heard about the plexiform neurofibromas. They're a benign type of neurofibroma, but they can get fairly big and cause problems just by the size of them. They can cause pain, or they can cause numbness or weakness, or sometimes mobility problems. Sometimes they're in the back of the throat and blocking the airflow, or swallowing issues. So, and these can be a challenging problem, even though they're a benign tumor. And you heard about some of the medicines that we have now for trying to treat these. But the real issue is that the way these tumors start is by people with NF1 have a genetic change in the NF1 gene. And then within the Schwann cells, early in development, if they lose the remaining normal copy of the gene just within that patch of tissue, they can get one of these plexiform neurofibromas. And then it can genetically stay the same for many, many years. But at some point, there's about a 10% lifetime risk that this benign tumor will acquire some other genetic changes that would make it into a malignant or cancerous tumor. So that lifetime risk is similar to the lifetime risk for an average woman to have breast cancer, or the average man to have prostate cancer. And those are the two most common cancers in men and women overall. So it's not an insignificant risk. Fortunately, it's only 10%, but we'd like it to be even less of a risk. And the way that we maybe do that is to detect it early, as Dr. McNeil Knapp already suggested. The median age, if you did all the age range of people who get this tumor, the middle number would be around age 40, but people can get it older than that, or even much younger, even as teenagers. The risk is higher in some of the people with NF1, particularly certain types of genetic changes that cause NF1, one of them being the people that have the NF microdeletion, which means instead of having a spelling change in the gene, they have a missing piece of the chromosome that includes that gene and some other genes. Also, there's some specific positions within the gene, thank you, that these positions that I marked here, 844 to 848, that increase the risk. And if somebody's had a previous history of one of these, either the malignant tumor or the early, firm nodular tumor that Dr. McNeil-Knapp talked about, the atypical neurofibroma, that increases the risk. And as she said, the treatment has to be through surgery, sometimes with the addition of other things like chemotherapy or radiation therapy. But the main thing is, the problem is that those treatments, if we can't get the whole tumor removed with surgery, then there's a fairly high chance that it's going to come back. So that's what we mean by recurrence. It's kind of like if you have a weed in the backyard and you don't get the roots out, it will grow back. And that means that, over the next 5 years or so, the survival rate is less than 50% because of those reasons. So it's a very serious thing. The main issue is detecting it before it becomes this more aggressive kind of tumor. And one way to detect the presence of it is when these additional changes are happening in the benign tumor. It could cause pain or increased size of the tumor or growing rapidly, or a change in the texture, meaning like that firm, hard lump that's within a previously soft tumor. We may also be able to then do an MRI or a PET scan to detect the presence of this change that's happening in the tumor. But by then it may already be in its more aggressive state. Sometimes we can put a needle into the tumor, which is like a biopsy, but that can be hard because usually what happens is, I describe these tumors as kind of like a piece of fruit that's starting to have a rotten spot, like an apple with a rotten spot. And so the malignant part is the rotten area, but if you just put a needle into an apple, you might just only pull out the normal part of the apple, and then you're going to think it's a negative biopsy, and it's not really. So those can be tricky. So what we'd like to be able to do is have other techniques for detecting it early. And so just to summarize, a person has about a 10% risk of developing one of these within a plexiform neurofibroma over the course of their lifetime. It's usually detected after it's already become aggressive, and then the treatment outcomes are relatively poor. And early detection, we think, is the best way to improve that. One of the things that I've been doing for the last several years is I had a philanthropic gift to the hospital, and I organized an international consortium of researchers because there was very little information about the genetic changes that cause this tumor. And when I say genetic changes, I mean that they become very different than the normal genetic information that are in normal healthy cells. So just to give you an idea, what our consortium do, we got about 100 of these tumors from people who had NF1 and an MPNST and who agreed to participate in clinical research. And then we had samples from their tumors, and we did the genomic analysis of those tumors. And what we could see is when we compared it to the genomic readout of normal healthy cells, which you could see as in the plot that I showed there, those at the bottom of the screen, all those rectangular boxes. At the bottom, you see some black and gold stuff going along the bottom. That's kind of the genomic activity level or abnormalities in a normal genome is very quiet, very normal, flat. But in the tumors, it's very chaotic. There's a lot of genomic changes going on in the tumors. And there are specific areas of chromosomes that are very different than the normal. And so what we did is we characterized not only that there's a specific molecular signature of the malignant tumor, but also that we're able to detect it in a blood sample. So say, for example, the person has the tumor, it's getting more aggressive and having these genetic changes that are very different than normal genetic background. And little pieces of the DNA from the tumor are breaking off and floating around, circulating in the person's bloodstream. and we can take a sample of their blood and find those small fragments of DNA and tell how they're different than normal fragments of DNA that would be floating around in the bloodstream of a healthy person. So that serves as a marker of the presence of the tumor, and you could be a marker of the tumor even if the person's not having any symptoms. That could be very powerful in terms of early detection. So we're hoping that this would be a way that through a simple blood test, go to the lab and donate 1 to 2 teaspoons of blood and send it off to the lab, and then they can look for this molecular signature. We might be able to detect the presence of this tumor before it gets out of hand. And then we would have a better chance to remove it through surgery before it's caused, an aggressive tumor to happen. So the idea then is to get people who want to participate in clinical research who are at risk of this happening. And I'll explain what that means on the next slide. But this would be in adults 18 years and over who have NF1 and who have a plexiform neurofibroma, or what we call an atypical neurofibroma, like the early transitional version between normal and MPNST. And we would periodically collect blood samples, keep them in the biobank. And then if people did develop symptoms of an MPNST, they would, of course, get the routine care that they normally would get, like MRI and PET scans, surgery, whatever treatment is needed to try to treat that tumor. But at the same time, we'd be able to go back and get their samples out of the biobank and look for that molecular signature and see how early was the presence of the tumor detectable in the blood of that person. Now we know from research that's already been done, we can see the signature once the tumor is really, in its aggressive state. We just don't know how early we can detect it before that. So we would be doing a combination of normal routine care, but also checking the ability of this test to detect the presence of the tumor. So right now we've had this clinical trial open for about 3 months. We're attempting to enroll up to 1,000 adults with NF1 and observe them for 5 years, and that they would have to at least have NF1 and have a plexiform neurofibroma and live within the US. And in addition to that, we would be collecting blood samples every 6 months. We would ask them to fill out a brief survey online to talk about any symptoms they're having related to their plexiform neurofibroma and some questions about their quality of life. And then if they did get an MPNST tumor, which we expect to happen in a small percentage of all the people, fortunately. But if that did happen, then we would ask to collect some additional clinical information from the medical records and a sample of the actual tumor to do genetic analysis. The people that we're focusing on right now, and this QR code, if you scan that QR code with your phone, that will take you to our website for the trial. The people that we're focusing on right now are the people who we would consider in the high risk category, which is explained on the website, but it's things like this microdeletion or the other genetic changes that put people at a higher risk, or if they already have a lot of a high amount of plexiform neurofibroma, or they've previously had an atypical neurofibroma or an MPNST. And then we would do remote consenting. People don't have to travel anywhere. They would do remote consenting over a Zoom. We would have a blood collection kit shipped to their house. They could go to a local Quest Diagnostics and get a blood draw every 6 months. And in some cases, we can actually have somebody come to the house, but we can't do that for everybody. And we'll try to make it as easy as possible. We also offer a small financial incentive. So that's what I wanted to tell you about our study. I don't know if I've stayed within my time, but I think pretty close. But if anybody has any questions, I'd be happy to answer them. These are Ariana and Elena are the research assistants who work on my team, and there's information here either with the QR code or on the screen of how they can be contacted if people either themselves might be eligible for this and want to participate, or if they know of somebody who might be eligible and would want to participate in this.
Wonderful. Thank you so much, Dr. Miller. A few things I wanted to let everybody know, that in the chat, Dr. Miller's assistant, Ariani Polaria, I hope I'm saying that right, she also put something in there in the chat, so you'll see it with her phone number and her email address, so you can reach her there. And another way you can see this, if you for some reason don't get it on the screen right now, is it is also posted on the NF Network's website on their events page for this program. So you'll see it as well. We do have a couple of questions. One is, the study is 18, you have to be 18 years or older, is that correct?
That's true for this study. And also, I just found out this past week that colleagues of mine at the National Cancer Institute have opened up a new study that's through the NCI. And that one is, I believe, starting at age 3. So it includes
Right.
pediatric patients as well. It's not exactly the same as what we're doing, but it is intended as like patients who have NF1 and a plexiform neurofibroma, and it's for monitoring of, how do their tumors progress and to collect blood samples along the way, and so that's also available on clinicaltrials.gov. If you search for NF1 and liquid biopsy, you can find both of those trials.
Okay, great. We have a few more questions for you, and I think we have time. One is, there's one more question here. It says, is the outcome, let me see if I understand this right. If not, I will ask Drew to ask. Is there a greater likelihood of an MPNST transitioning from a plexiform neurofibroma?
Well, the goal of this study is how early can we detect it? So doing the study is not going to change the risk of the plexiform neurofibroma changing to an MPNST. It's more like if we know that's going to happen to a small percentage of people anyway, and if it's going to happen, we want to know what's the best way to catch it early. Is it through waiting for somebody to have, as soon as they have a symptom, we do an MRI scan? Or is it by, periodically, like at their annual checkup for the NF clinic, we get a blood sample and just screen that blood sample for DNA markers of a tumor? And if it comes back negative, we say, okay, well, no reason for concern here. If it comes back positive, they might not even have any symptoms yet. Now we send them straight to the MRI scanner to see if we can find where's the source of that molecular signature of a tumor coming from.
Okay, great.
Mhm.
We have another question. What is the shelf life of the blood sample?
Oh, that's a good question. Yeah, we're collecting it in special tubes so that it doesn't have to be rushed to the lab. It's easily fine at room temperature for a week. And then what we do is when we get the sample, we process it and put it in the freezer so that it can last for years, really. So we can go back and look at the DNA in the future if somebody. I want to point out, this trial is not actually, like, we're not testing the samples in real time and reporting back results to people. It's more like we have to wait and see what kind of information we get from this before we know whether that is going to be good as a clinical test. So it's not ready to be used as a clinical test yet. That's what the goal of this is.
That was my question. If
Mhm.
does the patient get that's another question. Does the patient get a report back of what the
Yeah.
indication is? It sounds like
Yeah.
we're not quite ready to use it as a diagnostic tool.
Not yet, but
Okay.
we're working on that.
And
Yeah. Go ahead.
okay, great. The other question is the quality of life component that you mentioned. Is that just kind of a side part of this, or can you talk about that a little bit?
It's particularly focused on the plexiform neurofibroma quality of life questions. So it's not like a comprehensive thing. It's more like, if you are having symptoms related to your plexiform neurofibroma, how much is that affecting you on a day-to-day basis? You know, how much is your pain bothering you? That type of thing.
Okay, great.
Yeah, that's a very minor part.
Okay. And then if I understand right, this is also available for Spanish speakers. Is that correct?
That's right. It's for English or Spanish, and so we have the ability to do. We have all the materials in Spanish, and including the consent form and everything that explains it.
Okay, wonderful. Let me see if there's any other questions here. I think this attendee is just asking, so what you're saying is there is a I don't know if you would call it a genetic test that's being done to find out if a plexiform fibroma will become an NPNST? That's a little
No,
tricky. I think we're having
it's
trouble
not.
understanding
Yeah.
that.
Okay. Yeah. Good question. So the test will not predict whether or not in the future a plexiform neurofibroma will become an MPNST. But if a plexiform neurofibroma is in the process of changing to an MPNST, it changes somewhat, it kind of happens slowly, that it slowly develops these additional genetic changes. Really all types of cancer, like in the regular population, any type of cancer is because of a new genetic change that has happened in some part of your body, and that genetic change has damaged one of the genes that normally protect the cells from becoming cancerous. And those types of damaging changes can happen just at random in a plexiform neurofibroma through the course of a person's lifetime. So we can't predict who it's going to happen to ahead of time. We can't predict where in their body it would happen. If they had more than one plexiform neurofibroma, it's not like we can predict. It's more like it's a it's same as like a fire detector, right? If you have smoke detectors in your house, that doesn't predict whether you're going to have a fire. But if the fire's starting, you get some warning at an early time so that you still have time to do something about it.
Great. Well, that's a step forward, a big step forward. So we'll take that. So let me see. I think we have one more question. Let's see. Is there one from Kansas City? It looks like. Maybe you can unmute yourself or put it in the chat.
Can you hear now?
Yes, we hear your question.
Just a quick question. You mentioned the gene, the sequence that was deleted that tends to be problematic. Would that be some sort of indication, if you knew that going in ahead of time, to keep an extra lookout for potential progression, like sort of like the BRCA gene now?
That's a great question. So so I think of genes as like library books. And sometimes most people with NF1, it's like they have a spelling change of one word in the NF book. And the whole book's there. It's just got one page has a spelling change on it. But that's enough to change the information. The microdeletion is like there's 10 books in a row missing off the library shelf, including the NF1 gene. So it's a bigger change. It involves about a dozen genes, and it about doubles the risk of a person getting one of these types of tumors during the course of their lifetime. So 10% up to 20%. And we do follow those patients more carefully. We do more MRI scans for them, for example, because they are at a higher risk. So good question.
Very good. Anybody else before we let Dr. Miller go? Okay, I think that's it. Thank you so much. We're all very excited about this.
Sharon, just a quick
And I'm
follow-up.
urging everybody to see us. Yes,
Sorry.
we have another
you
question.
Yeah, just a quick follow-up. Are you recommending that people actually be sequenced to look for that so that they're on notice?
Well, there's usually some other symptoms that go along with having the microdeletion. So because it involves more genes, usually those people have more severe learning disability or even intellectual disability. They tend to have some changes in their physical features that the NF experts are familiar with. So we usually have a pretty good idea who we need to do the testing for to look for that. Uh, so it doesn't mean we have to test everybody.
Good questions. Great. Well, thank you very much, Dr. Miller. Again, you can find the flyer on about the research study on the NF Network's event page. And we encourage everybody who thinks they even might be eligible to go ahead and reach out and see if you might be a part of this exciting study. So thank you very much.
Thank you for
And
having me.
we appreciate it and what you're doing for our community. And time for the next resource. It's coming. And I'll tell you a little bit about it. The next resource is a brand new podcast, and it was created by Shane Smith, who is a board member of the NF Network, and he's also a parent of a child with NF. And he wanted to bring topics of interest to our community, including NF2, so all and schwannomatosis, in an accessible and engaging way. He's had a few episodes already. He's featured a few guests, including researchers and parents. And I urge you to check it out. It's a great way to connect and get a kind of a taste of some topics that might be very interesting and important to different topics in different areas. So check it out. It's called Decoding NF. Thank you very much. Alana. Our next speaker, Michaela Bradley, is a genetic counselor beaming in from Michigan. She's going to share the results of her fascinating study on the effect of a family history of NF on adults with NF. So I welcome Michaela, and we're looking forward to your presentation.
Hi, thank you for that introduction. I'm excited to share. All right. Are you seeing my presentation?
Yes, we are.
All right, perfect. So I'm a genetic counselor currently working in cancer genetics, but for my master's thesis, I decided to look into NF1 a little bit more. This was something near and dear to me as someone with the personal diagnosis of NF1. And so I'm excited today to talk about the results of my study that focused on stress and coping in neurofibromatosis type 1, and specifically the role of family history. All right, so just to start with some background information and my research goals. So there's already a lot of existing research about stress and coping in the NF1 population compared to the general population. So first, mothers of children with NF1 had higher levels of stress compared to mothers of healthy children, and this is often accompanied by parents' worry about what their child's life might look like with NF1 and wanting to do what's best for their child. Additionally, adults with NF1 have been shown to have higher levels of stress compared to the general population, as assessed by measures like the perceived stress scale. And this has been used in many studies that have shown similar results of adults with NF1 having higher stress compared to the general population. Women and men with NF1 have lower scores than the general population when measuring quality of life. And then avoidant coping strategies were correlated with physical distress in people with higher levels of physical manifestations related to their NF1 diagnosis. And so this just provides some foundation showing the background knowledge that we already have about stress in people with NF1. And then I want to talk briefly about what we know about the family influence related to NF1 diagnoses. So studies have shown that parents express concern about passing the condition on to their child and what that might look like for them. Participants have shared that comparing their signs to those of family members help them evaluate how NF1 might impact their own lives. And there have been cases shown where downplaying the effects of NF1 in everyday life was connected to less talking between family members about NF1. And again, parents have shared concerns about watching their child develop signs of NF1 and have reported they monitor their child closely after diagnoses. So this brings us to my research question, which was, does a family history of neurofibromatosis type 1 influence the levels of stress and coping strategies of adults with NF1? So in our study, we had 3 major goals. First, we wanted to evaluate stress, and we did this by comparing stress scores between participants with and without a family history of NF1. So we were asking people, were you the first one in your family with NF, or did you have an affected parent? And that's how we split up our 2 study groups. We also wanted to evaluate coping by comparing coping scores between participants with and without a family history of NF1, and explore if family dynamics influence the experience of NF1 stressors in our study population. And taking into consideration the existing research and some of the information I shared at the beginning, we came up with 2 hypotheses. So first, it was hypothesized that individuals without a family history of NF1, so people whose parents were unaffected, would have higher levels of stress compared to those with the family history. And current research shows that being the first person in your family to experience a chronic illness can be unexpected and isolating, leading to increased stressors. Second, it was hypothesized that individuals without a family history, so again, those people whose parents are unaffected, would have lower level of adaptive or positive coping strategies compared to those with a family history. And we thought this because current research shows that having family members who have experienced NF1 might expose patients to coping strategies that they can adopt for themselves. So now I'll touch briefly on the methods that we used for this research. So to be included in our study, participants had to have a personal diagnosis of NF1 that could be clinical and or genetic, be at least 18 years old, live in the United States, and speak English. And so we used an electronic survey that was sent to 3 recruitment sites. This included the Children's Tumor Foundation's NF Registry, as well as CTF's NF Clinic Network, and then the Neurofibromatosis Network. So really trying to capture people who might be plugged in for research, for clinic, or for more general support. And there were 6 major study components. So we asked questions about people's personal history of NF1, things like what features they experienced, how they perceived their diagnosis and severity, as well as more about when they were diagnosed and things like that. We asked about family history of NF1, and then we had a couple of measures to look at stress and coping. So those were the perceived stress scale and the brief coping orientation to problems experienced inventory. Then we had some short answer questions to get more information about people's experience with NF1, and finally demographic questions. So to provide a foundation for when I discuss my results, I just want to touch on the 2 measures we used quickly. So the perceived stress scale 10-item version looks at perceived levels of stress in the past month, and higher scores on this scale are associated with higher stress. And then the brief coping orientation to problems experience inventory, or brief COPE, assesses coping on 14 subscales, covering different traits such as denial, planning, and emotional support. And we also divided these subscales into major coping styles of problem-focused, emotion-focused, and avoidant coping, as has been done in previous studies. All right, so now let's get into the results. So to start, here's an overview of our study participants. We received 646 total responses, and we were able to use 547 for analysis. This is because we had some responses that were duplicates and some cases where participants were adopted or did not know their parental NF1 status, so we couldn't assign them to those 2 study groups. So we ended up with 2 groups of people with inherited NF1 whose parents were affected, and then sporadic NF1 whose parents were unaffected. The average age of our participants was about 44 years, and this ranged from 18 to the upper 80s. And we had a largely white and female population, and then a decent split between inherited and sporadic NF1. So about 40% with inherited NF1 and about 60% with sporadic NF1. All right, so now starting with the results related to stress. First, we compared stress scores between participants with inherited versus sporadic NF1. That was one of the driving questions of the study. And we found no difference in stress scores between these two groups. So that kind of went against our hypotheses of those with sporadic NF1, thinking they might have higher stress, but we found no difference here. We also compared stress scores between females and males, and we found that females had significantly higher stress scores than males. And this is consistent with past studies that have looked at stress both in the general population and within the NF1 community. So given the large difference based on males and females, we also compared stress scores by sex and NF1 status. And again, we found no difference. So this graph just shows that in the blue on this first bar, inherited females and sporadic females, we found no differences in stress scores there, and same no differences between males with inherited versus males with sporadic NF1. So then in terms of coping results, participants with inherited NF1 scored higher on the positive reframing subscale of the brief cope measure, but we found no differences in any of the other subscales or their major coping styles. So again, this contradicted our hypotheses where we thought that people with sporadic NF1 would have lower levels of adaptive coping, but it was helpful to see these results and figure out what they might mean for the NF1 community. But we did find that higher use of avoidant coping or more negative coping strategies was correlated with higher stress scores, which has also been seen in past studies. All right, and then we did look at some other correlations between key variables and stress scores. So we found that an older current age and having higher levels of education were correlated with lower levels of stress. And then having a higher perceived severity of someone's diagnosis, having more NF1 features, and having learning differences were correlated with higher stress scores in our participants. All right, and now I want to talk through the findings from our 3 short answer questions that ask participants about their experiences with stress, coping, and family communication related to NF1. And this is the part of the study where I feel like we got really great insight from people about what NF1 looks like in their everyday life and how they think about it in these areas. So our first question was, what parts of your NF1 diagnosis are most stressful for you? And we identified 3 major themes that were shared amongst all our participants. So the first was NF1 symptom burden, with subthemes of the impact of NF1 tumors and the impact of other NF1 symptoms. And so over 30% of our participants reported that NF1 related tumors are a major cause of stress. And other symptoms that people shared included chronic pain and learning differences. The second theme was the social impact of NF1, with subthemes of physical appearance and negative social experiences. And some participants here shared experiences of being stared at or treated poorly due to their physical appearance, which then led to stress related to appearance or social interactions. And the third theme centered around medical management with NF1, with subthemes of uncertainty of NF1 and symptom progression, family planning, and lack of access or treatment options. So here we learned a lot about how not knowing what life with NF1 would look like in the future or if their children would be affected caused participants a lot of stress. Our second question was, what strategies do you use to cope with stressors related to your NF1 diagnosis? Here we identified 5 themes, 3 of which were related to adaptive or positive coping, and 2 related to maladaptive or more negative coping. And again, these themes were shared between our 2 study groups. So first, participants reported that they accepted the diagnosis and used a positive mindset. For some people, this looked like acknowledging that NF1 is a part of their life and trying not to focus on the more difficult parts of their diagnosis. Second, participants reported engaging in activities such as exercise, reading, meditation, prayer, or other preferred activities as a way of coping. Third, we learned a lot about support systems with this question. So support systems were a big way that people coped, and this included subthemes of emotional support informational support, and mental health or medical support. So this might look like talking with a friend, family, or seeking therapy. And then for maladaptive themes, we identified avoidance and having no coping mechanisms. In these cases, participants shared either actively avoiding things related to their diagnosis or not currently having any ways to cope with their stress. Our last question was, how did your parents talk about your NF1 diagnosis with you? And we had 4 major themes here. The first was the levels of communication with parents, and we had 3 sub-themes. So first, almost a third of participants reported that their parents did not talk with them about their diagnosis. And then we also learned that more individuals with inherited NF1 shared that conversations were limited compared to those with sporadic NF1, sharing where they had more general conversations with their parents. And lastly, some people shared that most of their conversations were with other people, like their doctors or their own children. And a lot of people said they wish their parents had talked about their NF1 diagnosis more. The second was barriers to conversation. So here being themes like diagnosed later or the lack of information about NF1. And in these cases, some participants were diagnosed as adults or during a time period where there wasn't a lot known about NF1. So these things led to less conversations within the family. And finally, we had cases where people reported positive experiences versus negative experiences with family. So some participants shared their parents were supportive and helped them understand their diagnosis. On the other hand, some participants mentioned their parents were not helpful or would say hurtful things related to their diagnosis. So I know that was a lot of results and information in a short amount of time. So now I want to summarize the impact of these findings for patients, and I'll be happy to answer more questions or talk more about any of these things once I'm done. So thinking about some impact for patients, our study suggests there's no significant differences in overall levels of stress or major coping styles between adults with inherited versus sporadic NF1. Sex, current age, perceived severity, and level of education were correlated with participant stress levels. And we know that every individual with NF1 has unique experiences. So these results show a subset of those experiences, and it's important for providers to listen to patients and treat their individual needs. And then there are many factors that can increase stress related to someone's NF1 diagnosis. We also know stressors can change over time, and they're different based on the individual. And in our study, common areas of stress were related to symptoms, social interactions, and uncertainty. There are also many ways to cope with stressors related to NF1, but it's not always easy to develop and use coping strategies. And we found that a lot of people share that engaging in preferred activities and finding support were helpful for them. And lastly, family communication about NF1 can look really different between individuals and based on the family situation. And now just talking a little bit about the role of genetic counselors. So genetic counselors can play a key role in supporting patients through various aspects of their NF1 diagnosis. We're here to provide information about NF1. We can help facilitate genetic testing, talking about the family history and who else in the family might benefit from seeing genetics, talk about different family planning options, and then focus on psychosocial counseling, which for us means talking about adaptation, processing, and coping with the diagnosis, and also help facilitate additional referrals. So before reviewing the conclusions, I want to acknowledge some limitations. First, our sample was largely white and female, and we know that NF1 is thought to affect all sexes, races, and ethnicities equally, so we may be missing some perspectives in our study. Second, our participants may have been more likely to participate in research or support groups, so we might have missed people who don't connect in those ways. And third, we want to acknowledge the accessibility. We used lay language and added features to our survey, such as text to audio and large text size, but we know that about 50% of individuals with NF1 have learning differences. And while 52% of our participants reported learning differences, we want to note our study still may not have been accessible to all. And so finally, to wrap up, a family history of NF1 did not impact stress or major coping styles in adults with NF1. Knowing what factors may influence stress and coping in individuals with NF1 can inform providers about what patient groups might be at risk for higher stress. Talking about individual stressors and identifying positive coping strategies could help promote stress management. Future research could explore stress and coping in children, and then genetic counselors can help patients navigate many parts of their NF1 diagnosis. And I would just like to acknowledge my amazing thesis committee who helped me with this work. So Emily, Ashley, Bryce, Dr. Moots, and Kelly. And then additionally acknowledging the organizations that made funding and recruitment for this study possible, including NF Central Plains. And again, thank you to all participants who took the time to complete the survey and share their experiences with our team. And here are the references I used. And so now I think we might have time for some questions.
I think we do. We have a few questions for you, Michaela. Let's see. So one is, and you may have touched on this briefly, do you intend to do anything with these findings, or is there any, I understand they'd be very helpful, but do you have any intentions to do further study or to do anything with this particular study's results?
Sure. So right now we're in the process of publishing our research. So we have submitted our first paper for publication that focused more on the results that we found from the stress and coping measures. And we're also working on a paper that explores more of those short answers and the lived experience of people, just to help get that information out there. And I've also been giving this presentation to other groups, some of which are other providers too, just to help people in the NF1 community be aware and learn from this research, since we had a pretty big sample size to help kind of learn about the stress and coping experiences.
Great. We will look forward to reading those publications, so that's great. Another question is, and I don't know if you tested this, would it make a difference, or did it make a difference, or did you look at whether the parents who had NF, how severe their case was, or do you think that would make a difference, or was that even looked at?
That's a great question. So we did ask a question where we had participants say if they thought that their NF1 diagnosis was more, less, or the same severity as their parents' NF1 diagnosis. So getting that information from the participant, not directly from the parent. And with that information, we didn't find any differences within our study.
Okay, great. Let's see. There is one here. There's one here about, it says your second conclusion, let's see, about how it correlates with the demographics, sex, education.
Mhm.
Let's see, was that, you might have to go back to your slide before we can see what this question is asking. Thank you. It might have been,
Back a little more.
yes. Okay, this one, it's the second one. So can you explain that a little bit more, the second one?
Sure. So this is just kind of tying in some things from the results earlier. So with this, we found that females had higher stress than males. We found that older individuals had lower stress. People with higher perceived severity had higher stress, and people with more education had lower stress. So that sentence was just kind of summarizing the results from the past slides.
Okay, great. And when you say had more coping, were there any specific findings? For example, was it tied to they had more support from groups or through therapy, or what specific coping tool was used, or not necessarily?
So this was for stress. We didn't find any of those differences for coping. The only difference we found for coping was people with inherited NF1 might use positive reframing a little more. So kind of taking a negative situation and looking at it through a more positive light. But there were no other differences we found with these variables for coping. Those were only for stress.
Okay, great. Let me see if there are any other questions. I don't see any more at the moment.
All right, and I'm
Um,
happy to take other questions if anyone or talk more about my research. You can reach out with my email. There's obviously a lot more than what can fit into 15 minutes. So
yes, I know we're on a time crunch, but feel free to reach out to Michaela directly, or you can, if you want to post through the rest of this event in the chat, we'll make sure that your questions get directed to Michaela. Thank you so much.
thank you.
There is one other question in the chat room. Do you want to read it?
I see that, but I'm not sure it's directly related to this
Oh, okay.
presenter. So I think we'll direct it to somebody else and make sure it gets answered as best we can. So, all right, thank you. And now for your next resource. Your next resource was this next one that we're going to share with you, was also developed by the NF Network. And I think Dr. McNell-Knapp touched on this, which is the increased risk of breast cancer. And this piece was created by the NF Network to educate patients and their doctors about the increased risk of breast cancer in women with NF. The most recent recommendation is that screening should begin at 30, which is earlier than for the normal population, the general, I should say, population. These are the guidelines of the National Comprehensive Cancer Network. And so this piece of literature can be used in case somebody, for example, asks for their doctor for a mammogram earlier and they are given the response that insurance won't cover it. It should be covered. And so this is just a little bit more ammunition for you to use. And it has a human interest story there. You see Bev, and you can use the QR code that's on the screen to get some more information, or you can find this on the NF Network website as well. So I encourage you to check it out. Thank you, Alana. And now it is my honor to introduce our final speaker, Dr. Aditi Gupta. She comes to us from Washington University, where she is collaborating with the NF clinic there to explore how artificial intelligence can be used in the NF arena. We're so privileged to have you here with us. Thank you so much. Welcome, Dr. Gupta.
Thank you. I'm just going to try and share my slides and would need your help in confirming. Just
Okay.
second, let me.
And while she's doing that, I will encourage people, if you have any questions, even on prior speakers, please put them in the chat room and we'll make sure they're directed to the presenters. You are on. We can see it perfectly.
And you can see the whole screen with the presentation?
Yes. Looks
All right.
good.
All right, thank you. So good afternoon, everyone. Thank you for inviting me today. I'm an informatician, and I'm here to present our work on leveraging artificial intelligence for personalized risk assessment in NF1. In this talk, I will provide an overview of how we created an AI model to analyze the data for individuals with NF1 and develop clinical tools to predict the disease, but at an individual level. Before I actually dive into the details of our study, I wanted to set an outline for some of the foundational concepts. First, what do I mean by AI? And now AI can have multiple definitions. It can mean different things to different people. But the one that resonates the most with the work that I'm showing today or with me is that AI enables machines to learn from experience, adapt to new inputs, and execute tasks that resemble human capabilities. In simple terms, AI allows computers to learn from big data sets and then find important patterns in it. So now that we've covered what AI is, let's explore what is specifically the role of AI in biomedicine. So AI has the potential to significantly enhance human decision-making in biomedicine. We are not talking about AI replacing doctors or caregivers. Instead, we want to develop AI methods as tools that doctors can use to aid in their decision-making process at the point of care. Humans make sense of the world by recognizing the different patterns and the data around them. Similarly, computers can identify patterns, but at a much faster rate and on a much larger scale. Our objective is to use AI to analyze extensive data sets and support clinical decisions. To achieve this ambitious goal, we assembled a team from the Institute for Informatics, Data Science, and Biostatistics at WashU, and we collaborated closely with the clinicians at the NF Center. So the work I'm presenting here is actually on behalf of this team. And our team included informaticians like Dr. Philip Payne and me, and the NF1 clinicians, Dr. David Gutman, who was the pioneer and the one that he got the idea to us of this should be done and AI can be used in this project. And then we also have Dr. Stephanie Morris, who was earlier at WashU, now has moved to Kennedy Krieger, but continues to be a very close collaborator on this project. So the primary aim of the study that I'm presenting here today is to develop an early warning predictive model for 3 key subphenotypes of NF1. So the ones that we are going to build predictive models for is optic pathway glioma, attention deficit hyperactivity disorder, and scoliosis. These predictive models can help clinicians better understand which individuals are at a higher risk for these conditions and take preventive actions and do closer surveillance. We emphasize the term early warning here because our goal is for the data and algorithms to predict if an individual is likely to develop one of these clinical features before they are clinically diagnosed. The early warning system can provide timely alerts to healthcare providers. And leveraging machine learning to improve the risk stratification has the potential to enhance and improve clinical outcomes. The data that we will use for this study comes from the electronic health records or electronic medical records, EHRs or EMRs. We use those terms interchangeably here, which are routinely collected. So I wanted to also give an overall description of what is the process that is followed to create AI models. It essentially involves 4 key steps. The first one being to acquire data. In acquiring data, so the data can come in multiple forms. For example, we can have numeric data like the lab results, vitals. We can have textual data such as clinical notes. We even have imaging data or multimedia data when like X-rays and MRIs are done. So all of this, the first step is to acquire all of this data in a format that can be analyzed. The next is training a model. Once we have the data, we move to the training of a machine learning model. This model analyzes all the data that we have gathered so far and identify patterns and generate predictions for the specific health outcomes that we are of interest. After building the model, the next stage is deploying the model. And we essentially, in this stage, involves rigorous testing on separate data sets and to check how the model performs. And once we are sure and the model is well validated, it is only then deployed in a real world setting like a hospital or a clinic. Then our work is not done then, because the final step after deployment is that the model needs to be continuously monitored to make sure that it is performing at the level that we initially evaluated it for. So as new treatments come in, as there are changes in disease prognosis, the model needs to be updated in order to stay accurate. This is an ongoing process and it's iteratively defined. Our current projects is at the stage of the trained model stage, in which we are building ML models and we are checking its empirical evaluation before we deploy it hopefully in the next few years in a clinic. So before I get deeper into the actual workflow of the study, I wanted to talk about the details of electronic health records because they form the backbone of our analysis. So in the next slide, I will explain in detail how EHRs are collected. Okay. So the electronic health records data are essentially the digital version of a patient's complete medical history, which is meticulously curated by the healthcare providers. These include key pieces of information that are required for administrative and billing purposes, as well as for clinical workflow. And they are essential for a clinician's workflow to provide right care. So let's illustrate how the healthcare data is collected and utilized. Let's walk through an example of an individual who visits a doctor. When a patient visits a healthcare provider, the first step involves capturing basic demographic information, which includes patient's name, date of birth, sex, ethnic group, and additionally, the system assigns a unique participant ID to identify them in the system. Next, data related to the visit itself is recorded. For example, like the time of the visit, the date of the visit, which is the provider that they're seeing, which department are they going into. And then upon entering a doctor's room, the first thing that is done is that some initial measurements are taken. For example, information like height, weight, blood pressure, temperature. So all of these are recorded in the backend in the EMR associated with that particular visit. Further data collection includes information about treatments administered, any changes to medications, procedures performed, and lab results. Most of this data is structured, and when I say structured, I mean in tables, but some of this data is also recorded as unstructured information. So unstructured information is usually the notes that we often see a physician or a nurse practitioner type in while we are talking to them about our symptoms and other issues. Similarly, there are imaging information that's generated if we get imaging done, and that is also constituting the unstructured data. So essentially, why do we want to use EHRs or EMR for research versus like a more traditional database, which is have been curated for a specific purpose? So using EHR has its advantages. So the first being that it's real-time data set, allowing researchers to capture and analyze current health information. The second is that EHR is comprehensive and provides comprehensive patient information, which means that it has all medical history, it has imaging, it has labs, it has notes, it has the whole 360-degree of information that we need for doing an analysis. The second is, since they cover a varied and wide range of patient demographic, they help build models that are more generalizable. And the only other point I would highlight here is that they also reduce participant burden. So rather than like having people to do sometimes like long surveys or instruments, if we can extract some of this data from the EHR itself, that will reduce the time needed to do some of those surveys. So with all of those things in mind, we decided to use EHR for our analysis. And here is a typical AI or a machine learning workflow that is implemented, and this is how we did in our own study. So the first step is that we start by transferring the electronic health records data that we get into what is called a feature engineering pipeline. This pipeline converts all the raw data into a format that the machine can read. Excuse me. For structured data like labs, medications, and vitals, which are already organized into tables, this conversion is pretty straightforward. While other data, which is present in unstructured data or clinical notes, would need something further computation, for example, natural language processing, to be done. So for example, one of the important features that we extract is the family history of NF1. So that is something which is often written in the notes and not present in any table. So we kind of mine all the notes to extract those particular phrases to make it a feature in the machine learning model. So once both structured and unstructured data have been appropriately processed and converted into features, they can be fed into the machine learning model. After running the prediction, we then conduct various types of evaluation. These include empirical evaluation as well as clinical evaluation to make sure that the predictions are accurate and clinically relevant. So here are some of the details of the cohort that we are working with at WashU. So overall, we have a substantial data set of about 1,700 individuals who have a confirmed diagnosis of NF1. And out of these, about 1,047 form our pediatric cohort. This gives us a significant amount of data to build predictive models for this study. And for this study, we focus primarily on the pediatric cohort. On the right side, the map illustrates the geographic distributions of the individuals seen at WashU, BGC, NF Clinic. In general, data visualizations extract different types of information from the data set and help develop graphs to help us understand the data better. For instance, these graphs may show us like age distributions versus demographic characteristics, etc. So here's a look at another two graphs, which we use for some of the understanding of our data. The first graph shows the number of medical encounters the individual has. As you can see, most encounters are in the departments like pediatric, neuro, oncology, and hematology. This information is particularly useful when we are building predictive models, as they indicate regarding which clinical features are more associated with the cohort versus not. The second one is our age distribution with respect to the sex of the individuals. This slide is there to kind of summarize the process of how do we evaluate our predictive models. So, I mean, without going into the much details, the row here represents three different kind of machine learning models that we implemented, which are random forest, XGBoost, and logistic regression. Now, these models use various kind of clinical features. So all the electronic health records data that we collected are built into these feature matrices, which is then fed into these models for computing and predicting the outcomes. And then we use various kind of evaluation metrics like the AOROC curve and the F1 scores to see which models perform the best. So over here, I've highlighted some of the models. So like if in the real world implementation, I would select the XGBoost model because it's performing the best for optic pathway glioma, ADHD, and scoliosis. So this is a model that will be selected out of the all that were implemented. And then you can see that the results are better prediction values for optic pathway glioma versus ADHD and scoliosis. Yet we do get useful insights from these also. The other thing that these models do is that they are not black box model. We can actually get clinical features and indicators that tell us why did the model predict an optic pathway glioma for a particular individual versus not. And these important features or these explanations of why a model is predicting something is something which is being very useful. It's been something that our clinicians are really want to make sure that the model is able to give. They don't want a black box score, but rather they would want a score along with an explanation. So that's our goal. So moving on to one other crucial step in our research, which is to ensure generalizability of our AI models. Initially, we developed the ML predictive models at WashU. The next phase, which has recently been funded by the NIH, involves testing these models with data from a second site. So specifically, we have partnered with Lurie Children's Hospital in Chicago for this project. The advantage of doing this is significant. We do not want our models to be overly customized to just WashU data. By demonstrating that the same models also work on a data from a different location, like Lurie Children's, we can prove the robustness and applicability of our models. If we can show that our model performs accurately along both the data sets, we then have the opportunity to actually publish and share these models with like every NF1 clinic in the country. Last, I wanted to end by showing a research paper that we published a couple of years ago, and we have another one that's going to come up as a follow-up study for this. And in this, we analyzed different demographic and clinical characteristics, and we were able to highlight the important insights about NF1. We also applied machine learning techniques to develop and validate predictive models. With that, actually, that's my last slide. I think I did fine on time, but yeah, I'm here and happy to answer any questions.
I think you did great on time. There is nothing easy about condensing all of that wonderful information in such a short time. And all of you speakers did a fabulous job with that tough assignment. So thank you for that. It is fascinating. We do have a couple of questions here. One is, and I don't know if you can exactly how to word this, but does the patient have to consent to using the electronic records in this project, or is it just automatic, or does the patient have any role in this, I guess is what I'm asking.
Yeah, that's a great question. So this analysis that we do is more on the retrospective data set. So it is governed by an institutional review board. So WashU and like most of the other academic health centers have something called an IRB or the institutional review board. So we as researchers or any investigator submits a proposal to the IRB, and the IRB approves whether they allow based on the research question, based on the methods and the impact, they decide whether we are allowed to use this data. So we actually do not need patient consent because we are using retrospective data, which is present in a research database as part of the WashU system.
Great, thank you. The other question, this is an interesting question. How does the AI model deal with discrepancies in the EMR?
That's a very good question. So like we make, this is a big joke among data scientists that the 80% of our work is data modeling and data mining and getting the data in the right format and dealing with like, missing data, incorrect data. And it's only the last 20%, which is actually building the model. So I think there are multiple ways that we employ. We first look at missingness. Then we have other validation tools. For example, we look at like if there's a particular lab value which should be present in only a certain range, we check for those things. We check for like the units. There's methods applied like data imputation. So data imputation is an informatics method which you can apply to kind of put in missing data based on like either the average, mean, or median. So there are different strategies applied to different feature. So there's like not one solution that works for all, but that is something we do take into account.
Okay, great, thank you. Another question is, what are the next steps with these models to get them more broadly used by NF centers around the country?
Yes, so actually that is something that we are working on. So our goal with the second site at Lurie Children's is that we are able to test it out at a second site. And the moment we are able to, so at least we'll have a 2-site model that's validated. But then our goal is that if we can get more and more NF centers to kind of adapt this model, or if we can test it out on their data set. So that is going to be definitely the next goal. It's going to be hopefully be there in a year or two that we will be out there. So it's going to be, since it's an NIH funded grant, all the algorithms models would be published freely in papers and on like GitHubs and other code repositories.
Great. And I would imagine with AI technology improving so quickly that will help hopefully speed this up. So
yes, definitely the large language models and the GPTs that have come into play in the last few years have really kind of really evolved the landscape of extracting data from clinical notes. It is very easy to extract phenotypes from clinical notes now with the incoming LLMs and GPTs.
Great, great. Somebody has asked what the clinical requirements are to use AI models in patient care.
So again, there are like institute review boards that exist. So right now, the work we are doing is more in a lab setting and a retrospective data analysis. But when we are ready, usually the steps are that you do a silent prospective trial with. So again, you approach a particular review committee, which reviews a proposal, looks at the results to validate whether the results are accurate or not, and then you can run a trial silently to kind of see how it's performing in real time. And then once it's even past that stage and it's validated, then it is something which is developed as a UI to be implemented in the real world. So it's like pretty much like clinical trials. It has multiple steps in it. And there are institution review committees that are established to make sure that nothing which is half-baked is implemented.
Great. Do you expect, I know you said you're focusing on the pediatric population. Do you expect a different result as far as applicability and robustness in the adult population?
It would depend a little bit on the clinical feature that we are building the model for. So the thing with why we selected these 3 particular features, which are more pediatric centered, is one, because of the clinicians that we were working with. So Dr. Gutman and Dr. Morris are both focused more on pediatric NF1 patients. So that's why those were the clinical conditions that we started off with. But then also because of the fact that we are doing machine learning, we do need a substantial number of individuals in a cohort to be able to make meaningful ML models. So so if a condition has substantial number of data points and big enough cohort, then I think our results would be like similar in pediatric and adult population.
Great, great. And then the only question I had is just to summarize, to me, it seems like the greatest advantage is the predictability. Is that what you're seeing in practice? That's kind of what I'm trying to get the conclusion.
Yes, so early warning prediction. So like what we are trying to do is like before, like once the symptoms show up, it can be diagnosed in the clinic, but like can we do it even before the symptoms show up? So for example, things like optic pathway glioma, I think somebody in this call emphasized the need of detecting it early. So like based on the other clinical features, other kind of risk factors associated, can we predict this as like earlier than what is done in the clinic? So I think predicting it early is the goal.
Great. That seems to be a common theme today,
Yeah.
how important early detection is, and having a professional who's qualified in NF and an expert in NF to take a look and make sure we're catching things early. So this would be a great tool. Very exciting. Let's see if there's any other questions.
A question on this end? Yeah.
Sure. Go ahead.
Dr. Gupta, are you also incorporating any genetic information on your participants, missing gene sequences or that kind of thing?
So not in this current version, though we are writing a proposal. So that's what we call multimodal models. So in which we take different types of data together to build prediction models that can analyze multiple data sets together. So that's the next phase that we are building. So we want to get the modality of genomics data along with clinical data and then even imaging data, because a lot of these, some of the tumors, they are well represented in the imaging. So the next phase of the project is we want to include the clinical, genomics, and the imaging data all together in the single predictive model, but not right now. Right now, it's more clinical database modeling.
Great. Well, thank you so much, Dr. Gupta. Very, very exciting. So we look forward to hearing more about it in the future. Appreciate it very much. And I want to end on time, everybody. So I'm going to conclude with our last resource for the day. Take it away, Alana. This last resource is the NF Network News, and many of you have probably already subscribed to it. But the NF Network website offers a wealth of information and numerous resources. The NF Network News comes out regularly, usually monthly, and can be found on the NF Network's website under the NF News tab. And a lot of these things that we've talked about today, which are current research studies or impending research studies, are often highlighted in the NF Network's news. And speaking of research studies, we'd like to highlight a new one today that's focused on gene therapy. So we urge you to take a look. As with all of the research studies that Network and NF Central Plains promotes, your participation is crucial to moving these studies to clinical trials that may very well lead to treatments. So this one in particular is about gene therapy. We have the QR code and the link there. You can also find it on the NF Network's website. And it's really just trying to get your thoughts on gene therapy. So anyone just about is eligible to participate in this one. So we hope you will take a look and urge you to participate in this one as well. It's just a very, very important for us to participate to get this research moving along. And I want to thank all of our speakers today for their very informative and engaging presentations. We appreciate you taking time on a Sunday to do this. And I know I gave you a tough assignment to condense everything in 20 minutes. So we're very appreciative for all of the information. Many thanks again to SpringWorks Therapeutics for providing the means to offer this educational program, and to all of you for sharing your afternoon with us. You'll be receiving a survey in the next day or two, so please send us your feedback. It's really important, and we do take your comments seriously and take them into account when planning future programming. So now go enjoy the rest of your weekend. Bye for now.